Okay, eating disorders. This chapter discusses the disorders associated with the presenting complaints in chapter 16, which you might find helpful to read first. Anorexia and bulimia nervosa. Okay, we have this table that's talking about epidemiology of anorexia and bulimia nervosa. So, about anorexia nervosa, the prevalence is 9.9% for women and 0.3% of men. The sex ratio is 3 to 1, and some studies reveal that the ratio is 10 to 1, of course in favor for females. Age of onset, typically mid-adolescence. Bulimia nervosa, the prevalence is 1.5% of women and 0.5 for men. The sex ratio is about 3 to 1 also. Typically late adolescence or early adulthood. Okay. As with the majority of mental disorders, other biological and psychosocial factors have been implicated. Let's start with genetics. Estimates from twin studies suggest that around two-thirds of the variance in the liability to eating disorders is due to genetic factors. Genome-wide association studies in an anorexia so far have not identified any common risk variants, but have been underpowered. Early life experience. Premature birth and some perinatal complications increase the risk for a later eating disorder, potentially implicating epigenetic changes. Childhood adversity like physical, sexual, or neglect also increases the risk for an eating disorder. Relationship difficulties are often, but not always, found within families of patients with anorexia nervosa, including overprotectiveness, enmeshment, which is over-involvement with lack of differentiation between parent and child, conflict avoidance, lack of conflict resolution, and rigidity, resistance to change. Okay, these are some problems in the families of patients with anorexia nervosa. Okay, you can just highlight them. Okay. Personality. It is possible that the inherited liability might be mediated by certain personality traits, including perfectionism, okay, which is high attention to details, and rigidity and oppositionality. Okay. High scores in those domains are seen in unaffected relatives of those with anorexia, and in those who have recovered and have a normal body mass index, suggesting that these findings do not simply reflect the substantial cognitive changes associated with starvation. Cultural influences. In Western culture, the widely portrayed notion of the ideal body influences perception of body image, meaning that unusual thinness is often valued more than natural curves. The increase in eating disorders seen in low and middle income countries supports the concept that idealized thinness may influence risk for eating disorder, but it is very hard to prove. Neurobiology. The key neurobiological pathways underlying eating disorders remain to be clarified, but increased volume of orbitofrontal cortex, which is involved in the reward processing, has been found in anorexia and bulimia. Okay, orbitofrontal cortex. Both during and after an episode of illness, that suggesting that the findings are not merely a consequence of starvation. Okay. We've talked about the assessment, clinical features, investigations, complications, and differential diagnosis in Chapter 16. Hints and tips. Although depression and obsessive compulsive disorder may coexist with anorexia nervosa, these symptoms can also result from the effects of starvation. It is helpful to ask what happened first, and aim to restore weight before treating any remaining mood or anxiety symptoms. What about management? The management of anorexia nervosa. Ambivalence toward treatment, coupled with the psychological consequences of starvation like poor concentration, depression, and lethargy, means that anorexia nervosa is often difficult to treat. Treatment should be collaborative with an early aim of establishing a therapeutic alliance. This figure gives an overview of management recommendations by NICE Guidelines 2017. Okay, so if we have suspected eating disorder, we refer to multidisciplinary specialist eating disorder team. They assess for eating disorder and comorbidity, and risk the assessment for physical health and mental health. If low to moderate risk, you manage in community. If severe physical risk like sepsis, you admit to medical ward to treat. If severe psychiatric risk like suicidal, you admit to psychiatric ward. How you treat: psychoeducation about nutrition and weight, psychological therapy, we will talk about this later on. Medication, you can use multivitamin if low body mass index and so on. High physical risk requires safe refeeding with specialist advice. Okay. So, suspected cases should be referred to a specialist eating disorder service for assessment. Psychotherapy, preferably with familial involvement, is the treatment modality of choice for patients with anorexia nervosa. Here we have a table that lists the psychological interventions recommended by NICE Guidelines 2017. So we have some interventions for adults and others for children. First-line treatments for adults, one of these: CBT for eating disorders, Mantra, which is the Maudsley anorexia nervosa treatment for adults, or SSCM, which is the specialist supportive clinical management. Second line, different first line therapy. If you use one of these, then you switch to another one, and you can use focal psychodynamic therapy. This is for anorexia nervosa in adults. What about anorexia nervosa in young persons? The first line is family therapy, actually. That would be anorexia focused. The second line would be CBT for eating disorders and psychotherapy like adolescent anorexia focused and so on. For bulimia nervosa, the first line treatment in adults is guide self-help, which is CBT informed. The second line would be eating disorder focused CBT. For children or young persons, family therapy would be first, but here it would be bulimia focused, of course. And the second line would be CBT for eating disorders or eating disorder focused CBT. Okay. The interventions for anorexia nervosa differ in detail but have common principles. They are long-term, 20 to 40 sessions. They encourage regaining a healthy weight. They involve carers wherever possible, and they seek to develop a positive therapeutic relationship. Okay. The only medication recommended by NICE 2017 in anorexia nervosa is multivitamin. Previously, fluoxetine was often trialed, but this is now felt to be ineffective. A selective serotonin reuptake inhibitor may be of benefit in comorbid anxiety or depressive illnesses, but a return to normal weight should be attempted first, as this is likely to improve mood and anxiety. When prescribing for anyone who is significantly malnourished, be aware of the additional risks for medication in this group, particularly QT prolongation. Dose reduction and caution titration are likely to be required. Weight should be monitored and physical complications actively sought. Hospitalization is necessary in certain medical circumstances, like if the body mass index is less than 13.5, rapid weight loss, or severe electrolyte abnormalities. or if we have some symptoms of syncope, and psychiatric circumstances like risk for suicide or social crisis. In severe cases, patients can lose insight into the severity of their illness by virtue of both the psychopathology of the illness and the neurophysiological effects of starvation, where a patient lacks capacity to make decisions regarding his or her care and treatment. It may be necessary to use mental health legislation to effect compulsory admission to hospital and to initiate life-saving treatment. While mental health legislation in all UK countries only makes a provision for the compulsory treatment for mental illness, not physical illness, food is considered to be treatment for mental illness because it leads to improvement in the psychological symptoms, impaired decision making caused by starvation. Therefore, as a final resort, in certain cases, patients may be forced fed under mental health legislation. In extreme cases, nasogastric or intravenous feeding may be necessary. Red flag. A person with anorexia nervosa who is dangerously underweight and refusing to eat should be assessed for compulsory treatment, feeding under mental health legislation. Refeeding syndrome. When a patient starts eating after a prolonged more than 5 days period of starvation, care must be taken to avoid refeeding syndrome. This arises because of rapid switch from gluconeogenesis, which is the catabolic state, to insulin release stimulating glycogen, fat and protein synthesis, anabolic state, resulting in rapid intracellular uptake of the cofactors needed for this, such as potassium, phosphate, and magnesium. The associated electrolyte disturbances can be potentially fatal. Management hinges on replacement of fluid and electrolytes, which may need to be intravenous. To avoid it, refeeding is generally commenced cautiously, with frequent electrolyte monitoring for the highest risk period, first week of feeding, and with thiamine replacement. So here we have some clinical features of refeeding syndrome you should put in your mind. So we have hypophosphatemia that may be manifested as muscle weakness, hypokalemia as seizures, hypomagnesemia as peripheral edema, hyponatremia as cardiac arrhythmias, metabolic acidosis as hypotension, and thiamine deficiency as delirium. Okay, so all of these are hypophosphatemia, hypokalemia, hypomagnesemia, hyponatremia. Okay. Because of the rapid intracellular uptake of cofactors needed for the anabolic state. Okay, so red flag. Refeeding syndrome can arise in anyone who is malnourished, for example, alcohol dependence, postoperatively, and malabsorption syndromes. Hints and tips. Hypophosphatemia is the hallmark of refeeding syndrome. If you only remember one thing about it, remember to check for that. If it is significantly low, replace it, either orally or intravenously, depending on how low it is. Check local guidelines. Okay. What about bulimia nervosa? Patients with bulimia nervosa tend to be more motivated to address their eating difficulties and are usually of a normal weight. Treatment is predominantly psychological, ranging from psychoeducation, self-help manuals, and self-help groups in mild cases to individual cognitive behavioral therapy in more serious cases. Management by specialist eating disorder services may be necessary in severe cases. Inpatient treatment is not usually required. However, it may be necessary for treatment of electrolyte disturbances resulting from purging, which can be fatal, or for management of the risk for suicide or self-harm. Okay. So, inpatient treatment is not usually required. However, it may be necessary for treatment of electrolyte disturbances that resulting from purging or for management of the risk of suicide or self-harm. Antidepressants are no longer recommended to treat an uncomplicated bulimia. However, comorbid substance abuse and depression are common and should be managed as standard. Unlike with anorexia, mood and anxiety symptoms are unlikely to be due to malnutrition. Okay, what about prognosis? The prognosis of anorexia. Although weight and menstrual functioning usually improve, eating habits and attitudes to body shape and weight often remain abnormal. Recovery is slow. Time to complete remission in anorexia nervosa is typically 5 years. Around a fifth of patients make a full recovery. A quarter develop bulimia nervosa, and a fifth remain severely unwell. Okay, so 20% full recovery, 25% bulimia nervosa, and 20% remain severely unwell. The remaining, remainder tend to follow a relapsing remitting course. Okay. Risk for death in those with anorexia is increased sixfold relative to an age-matched population. Premature death is predominantly due to the complication of starvation because of arrhythmia and sepsis. And around a fifth of deaths are due to suicide. Factors associated with poorer prognosis are described in the books. Where's the books? Okay, and indicate that poorer outcomes are seen in more severe illnesses. So here we have the poor prognostic factors in anorexia nervosa. Long-term duration of illness, age of onset pre-puberty or greater than 17 years old, male sex, very low weight, binge purge symptoms, personality difficulties, and difficult family relationships. About the prognosis of bulimia, the course of bulimia is also variable, although generally better than anorexia, with 50 to 70% of patients achieving either full or partial recovery after 5 years. Risk for death in those with bulimia nervosa is doubled compared with age-matched controls. So, okay. It doubled. Okay. While for anorexia nervosa, it's sixfold. Okay. Poor prognostic factors include severe binging and purging behavior, low weight, and comorbid depression. Okay. Chapter summary. Eating disorders arise due to a mixture of genetic and environmental risk factors. The mainstay of treatment for both anorexia and bulimia is structured psychological intervention. Anorexia nervosa is associated with a high mortality, mainly due to physical complications of starvation. Admission to hospital may be required to safely manage high-risk patients with eating disorders, potentially using mental health legislation. Recovery is typically slow, and many patients have a relapsing remitting course. That's it. هذا والله تعالى أعلم وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين.